advised that today's conference is being recorded. If you require any further assistance, please press star zero. Thank you. I would now like to hand the conference over to the speaker today, Mr. Mike Schomer. Please go ahead, sir.
Thank you, operator, and thank you to everyone for joining us for the COVID-19 Daily Media Call for June 17th. We're going to start today with a situation report from Minnesota Department of Health Commissioner Jan Malcolm. Following Commissioner Malcolm, we'll get an update from Infectious Disease Division Director Chris Ayersmith. After that, we will open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. Around the world, as of early this morning, we were just under 8.2 million total cases of COVID-19 and just about 444,000 deaths. In our own country, as of this morning, the United States, we were just over 2.1 million cases and just about 117,000 deaths, a little under that number. Here in Minnesota, we are reporting more than 400 additional cases from yesterday, although as I'll discuss in a minute, that daily count is a bit of an over report. Our new total of cases is 31,296. Sadly, an additional 12 deaths were reported yesterday, bringing our new total to 1,325. The demography of these cases continues to be quite similar, and the geography as well, with these cases primarily located in the daily cases in Ramsey, Hennepin, Anoka, and Dakota counties. In terms of the hospitalization situation, there are 351 patients currently in the hospital, 181 of those in intensive care. So continuing that fairly stable and slightly declining population in hospital. As I just want to reinforce something that we've mentioned on prior calls, and you may note by looking at other data sources on the COVID-19 page and so forth, we do have a fairly high occupancy rate overall in our hospitals, particularly in the metro and southeast regions. But the high volume of hospitalizations are driven by all hospital business, so that represents all hospital care. And what we're reporting to each day are specifically the COVID cases, which have continued to decline pretty substantially over the last month or so. So back to the data kind of irregularity that you see in the last few days worth of data. We are reporting today a very large number of total laboratory tests of 19,586. But as we mentioned, I think on the call on Monday, there was a data reporting issue from one of our external labs that actually began over the weekend and persisted into Monday. That issue was resolved yesterday, and reporting is now fully up to date, but we did see a big backlog of test results reported to MDH yesterday evening. So that large number of total lab tests actually was spread over a couple of days. And the same is true for the number of cases, positive cases that we're reporting today. Some of those cases actually should be attributed to the days back to Friday, Saturday, Sunday, and Monday. So just to make the point, what we report to you, to the media and publicly each day on the website are the test results that are reported to us that day. But when we do the epidemiological analysis, and we do post the epidemiology curve on our website, that curve is constructed according to the date that the samples were actually collected rather than processed. So for those of you who are interested in looking at the epi curve itself on our website, that those data will be correct, as they will be attributed back to the test collection date. So I think overall, and Chris can certainly comment on this as well, while we're not going to go back and try to attribute tests or results to specific days, it does look to us that the general pattern over the last, the weekend and early this week just did represent kind of a continuation of the gradual decline in positive test results that we've been reporting. So that pattern appears to be holding at least to this point. Just would like to finally mention further update on the community testing sites. What we understand is that almost 2,000 people were tested yesterday in the 4 community sites that have been offering testing Tuesdays and Wednesdays. And that number is expected to be at about 2,800 today. Positive rates from those tests are still coming in, so we don't have complete counts yet, but as has been previously reported, we are finding around a 1% positivity rate in the latest batch of community testing results that we have. With that, I'll turn it over to Chris Airsmith.
Thank you, Commissioner. Just a couple of updates. We wanted to acknowledge activity that was happening in Mower County. Mower County has had 73 new cases and now has the second highest incidence of cases in the state. And we are working with Mower County local public health and emergency management to provide community testing this weekend. Testing is being planned for Saturday and Sunday in Austin, anticipating a capacity of about 1,000 each day. And then related to remdesivir, we received the good news of a new shipment of remdesivir last night. This time we got 1,960 vials, and a good portion of that was already sent out last evening to facilities, and more will be distributed today. So that is a drug that can be used with critical patients and helps to reduce the amount of time that they're hospitalized. So we're pleased about that. And with that, I will turn it back to Mike Schomer.
Thanks, Chris. At this point, we'll open it up for questions. And as we do, we'll ask that reporters limit themselves to 1 primary and 1 follow-up so we can get to as many as possible. With that, operator, we are ready to take questions.
Thank you, sir. As a reminder, everyone, to ask a question, you will need to press star 1 on your telephone. To withdraw your question, press the pound key. And thus we have our first question from the line of Tim Nelson from MTR News. Your line is open.
I wanted to revisit that Mower County issue. How worrisome is that? You're going to do some community testing. Is there anything else going on down there? And what do you think? Is it meatpacking again that's driving those numbers up?
Commissioner, do you want to start or do you want me to?
No, go ahead, please, Chris. Thanks.
Yes, obviously, when we see increases in cases in any area, we pay attention to that. In this case, we are seeing that there's been activity both in the community as well as related to a couple of large employers in the area. And so because of that, we're looking at, and there has been testing that's been going on, a collaboration between the health system and local public health and Mayo, and that's been going on, and that's helped to identify the situation and provide us with more information, and recognizing that there is both workplace potential for exposure as well as activity in the community. The testing is being expanded.
Thank you.
Sure.
Thank you. We do have another question from the line of Glenn Howard from Star Tribune. Your line is open.
Good afternoon. The remdesivir, I was looking at an HHS website that shows the shipments that went out to the states, and apparently there was no states received any shipment last week or 2 weeks prior. So from your standpoint, what effect has this had on the distributing this drug based on the demands? Are we seeing severe shortages because of these lack of shipment?
Chris, I don't know if you have any information on that. Please please feel free to answer it. So we could certainly get Dr. Linfield back on one of these upcoming calls to have a more thorough discussion about what we're learning from that. But Chris, if you may have some information.
Yeah, the only thing I'll say is that when remdesivir is available, that there is, everyone's very grateful and there is a demand for it. So the fact that we did not receive it for 2 weeks was not ideal. And so when it is available, we're grateful, and the facilities have obviously a use for it. And I would defer to Dr. Linfield to comment more on that.
Okay, and I was looking at your guidelines, and again, this may be for Dr. Linfield, but you issued guidance. It was revised this month, and it says that key worker status, I assume that's health workers, should not be considered in the May and June allocation as getting priority. Has that always been the case in the guidelines, or was this introduced recently?
Boy, I think I need to defer to Dr. Linfield. You said key worker status. Are you still referring to remdesivir?
Yeah. Ethical framework for allocation of remdesivir.
Oh, I see. Okay. Yeah, I still would want to defer to Dr. Linfield or Dr. Sarah Lim, who've been working with the ethical groups on these topics.
Okay. Understood. Thank you.
This is Commissioner Malcolm. I think we understand your question, so we'll have somebody get back to you this afternoon.
I appreciate it.
Operator, I think we're ready for the next question.
Yes, sir. Our next question comes from the line of Catherine Richards from Minnesota Public Radio. Your line is open.
Hi. I have a couple of questions about ICU beds. You mentioned that the fact that we're nearly full has more to do with other hospital cases that are unrelated to COVID. Still, though, do you have any concern about the fact that we're near capacity on that, or does that still track with what you guys are sort of used to dealing with pre-pandemic?
Great question. This is Commissioner Malcolm. This is not an atypical summer pattern, so I think it falls within the range of normal operations. But just the fact that there's not a lot of slack in the system is something that we've talked about in the past, but I think it's one of those interesting lessons learned going forward, that we really have seen pretty sizable shrinkage of inpatient hospital capacity over many years now, and that has left the system with less surge capacity, if you will, that's just available on a kind of a routine basis, which is what occasioned the need for all this extraordinary planning about how to create surge spaces if they're needed. So the fact that we are running at a high level of capacity with remaining uncertainties about what may happen with future increases in the number of people needing treatment for COVID is a concern. But I think, again, the planning that's been done and the surge capacity that's been identified is kind of what makes us still feel like the situation is about in as good a shape as it could be at this point.
Would you foresee pulling back on elective procedures and other surgeries again if we started to see more COVID patients coming into the system, free of that space?
Well, I think that is among the tools that we would have, and in fact, in the guidance that was issued relaxing the restrictions on elective procedures, that was a feature of the plans that facilities needed to do, was they're keeping an eye simultaneously on the potential demand for increased capacity to be reserved for COVID-19. So it's kind of built into the way the systems are operating now, with an eye to how they're doing scheduling and how they're looking out ahead. But yes, we could either on a regional or larger basis revisit that if we need to.
And are most of the numbers that you're seeing of COVID ICU patients, are those mostly still in the cities, or are you seeing those numbers rise in other parts of the state, especially where we're seeing some outbreaks, for instance, in Malware?
Yeah, Chris might be able to comment further on that. This is Commissioner Malcolm still. Yes, definitely the critical care utilization is kind of concentrated in the metro and in the southeast, but as we know, sometimes those cases are coming into those centers on referral from elsewhere around the state. So I don't actually know all the resident status of the ICU patients. Perhaps Chris does.
No, I would second what you said about the metro and the southeast having the greatest utilization. But as you said, people are often transferred for care, so that if you're being cared for in the southeast, it may be because you've been sent to Mayo, not because that's absolutely the location where you live.
Thank you, presenters. We do have another question in the line of Walz from Forum News Service. The line is open. Please ask your question.
Hi, I just want to ask you a question about the county case rate per capita map on your website. It looks very different than the map that just shows the cases per. Just wonder. Counties with me.
And Paul, say that again. When you look at the is it positivity by county or incidence rate by county?
Per capita. So you have a per capita map, and it shows like 9 counties in southern Minnesota, a host of counties in central Minnesota. Both Hennepin and these are all the highest. And I'm just wondering if this tells us anything about that. It actually is in greater Minnesota to a greater extent than we appreciate.
Certainly we know that we're seeing COVID activity across the state. And in greater Minnesota, as you said, some of the areas with the densest, the darkest colors in terms of, rate per capita are those locations where there have been cases linked to a work site. But if you look at the map, you can see that we're seeing cases across the state. So we certainly don't want people to think that there's, you're safe in a certain area of the state, but there are obviously differences, and oftentimes it is because of a cluster related to a workplace that we start to see more activity, particularly in greater Minnesota. Does that answer your question, or please ask again if I did not answer?
Yeah, no, it does. It didn't all seem like counties that were home to these outbreaks. So I didn't know.
Yeah, one thing to keep in mind is that in some situations, you'll have the home base of a particular employer, and the location of the facility is in a particular county, but then employees will work in multiple surrounding counties. And then there have been a number of work sites that have garnered a lot of media attention that I think people are more familiar with, but there have been additional work sites where there's been testing done that may not have attracted quite as much attention, and that is contributing to what you're seeing on the map as well.
Actually, thank you.
Thank you, sir. Again, everyone, if you would like to ask the question, you will need to press star 1 on your telephone. Our next question comes from the line of Michelle Cortez from Bloomberg News. Your line is open.
Thanks so much for taking the question. It's been over 3 weeks now since the death of George Floyd, and it seems like we would be starting to see an increase of cases if they were related to the protest. Is that accurate? Is that expectation on my part accurate? And since we haven't really seen a dramatic increase, can you draw any meaning from that? Thanks.
Well, this is Commissioner Malcolm. I'll start, but certainly want to ask Chris to comment as well. I think certainly it's encouraging that the patterns that we've been seeing are still holding. We do think it's still a little early to draw any definitive conclusions. And certainly we're going to be learning not only from our own experience here in Minnesota, but the protests that have happened all over our country and indeed internationally. That's going to be quite a lot of data and learnings to be gleaned from those experiences. I will say that we are learning from the experience of some other states that it might be prudent to give a little bit longer window to see the full effects of environmental changes, whether that's in reopening policies or the impacts of these mass gatherings. That it may, some states, I think folks have observed that some states thought they were in pretty good shape in terms of the stability of the growth rate of their epidemic a couple of weeks after environmental changes. And then a couple of weeks after that is when the big spike began to emerge. So it's perhaps ideal to look at a longer period of time, a couple of incubation cycles to really get the full picture. But I'll let Chris comment further.
Yeah, I absolutely agree with what the commissioner said, and we have talked. I just want to be clear that when you mentioned the 3 weeks, we have talked about the incubation period is 14 days. We need a little bit of time to get things reported, and so absolutely we're delighted that we are not seeing a huge increase in cases. But as the commissioner said, we want to make sure that we're looking at not only our own data, but the collective data nationally as we look at the impact of these mass gatherings. And we'll continue to monitor things for the next weeks just to make sure that we don't see any changes as we look at, potential second generation. But just to be clear, I don't want anyone to think that we're never appreciative. We are very pleased and grateful both for the low positivity that we're seeing and for the plateauing and even in some cases reduction in numbers. I mean, that's good news for all of us, but we want to be cautious in terms of how we interpret what that means for going forward. We just want to have a little bit more positive data before we do the happy dance completely.
Again, everyone, if you would like to ask a question, you will need to press star 1 on your telephone. Again, that is star 1 on your telephone keypad. Presenters, our next question comes from the line of Jennifer Riddle from ABC6 News. Your line is open.
Hi there. Thank you for taking my question. I just wanted to clarify something that Chris, you had said earlier about the cases in North Beach. And he mentioned that it was the second highest number in the state. And is that just in new cases that were reported today?
No, that would be the collective activity. And we're at, there are 734 cases in Mower County at this point, or as of last evening.
Okay, thank you.
Do you have any more questions?
Yes, sir. We have a question from the line of Chris Serious from Star Tribune. Your line is open.
Well, thank you. So over the past few weeks, we've seen several cases in the death records of people who have died from social isolation, where at least it's been listed as one of the causes for a person dying in a long-term care facility. And I know you've been working on some new guidance around that. I just was interested in an update on that, and also whether you've heard of any cases as well of people in long-term care facilities dying of isolation.
Hi, Chris. This is Commissioner Malcolm. Well, we absolutely know that social isolation and emotional disconnectedness is a major health concern in its own right, and the separation that has happened for residents of long-term care facilities and their loved ones is just one of the most heartbreaking things about this epidemic to date. As you know, we announced just the other day some guidance on our website for safe window visitation practices, just creating some more advice and guidance and structure around how that can be done in the safest manner possible. We are working on outdoor visitation guidance. And as I think I mentioned before, these are, we think, on their own right, good steps, but we very much appreciate that there's a lot of interest and need to figure out how we can best strike a balance, which is a difficult balance, I think, but between restoring more ability for residents and loved ones to be together safely, but while still kind of acknowledging and guarding against the act of just the fact that further opening up of social interactions in the community and in these facilities will add to the risk that's already present in congregate settings. So it's a tricky balance to strike. We are working in a collaborative manner with healthcare providers, long-term care providers, researchers, and elder advocates to try to make sure all perspectives are kind of expressed and on the table and considered as we try to strike that balance, because we really are extremely aware that a holistic look at the health of folks in long-term care settings is really, really important. So in terms of specific evidence that we see in death records of some of those other health effects, I'd turn to Chris on that.
Yep, and so, Chris, just kind of a little bit of a technical bit here. When staff from our Office of Vital Records looked into this, there's really not an ICD-10 code. So the coding that would be used for how we code death certificates, there is not a code for social isolation, exclusion, or loneliness in the CDC National Vital Statistics System. So we looked into this, and we identified 2 cases that had this same cause of death identified. They were filed by the same certifier, so there were two situations, but we did not find additional, but that may in part be because there is no code for this type of cause of death for the national coding that is done.
Okay, thank you.
Thank you. We have another question from the line of Chris Rogers from Winona Post. Your line is open. You may ask your question.
Thanks, Commissioner. Thanks, Director. I wanted to ask about the staffing support for long-term care centers that was part of the battle plan, and how many relief staff people are currently available, and how does that compare to the number of staff working in long-term care facilities in Minnesota?
This is Coach Malcolm. I can give you sort of a general update, but we could get back to you with a more quantified answer. We're gratified that we're not seeing as many staffing or kind of urgent staffing situations in recent days as we did, a month or 6 weeks ago. And I think that's a result of working more intensively with facilities on helping them think through and supporting them in developing contingency staffing plans, so that they're better prepared to potentially see that coming and to have a plan in place for how to manage it. We have been been doing a lot of work to create volunteer pools and ability to match facility needs with short-term volunteers. We've had some emergency staffing available to send in on short notice to cover short shifts and the like. And I think but in terms of the specific number of shifts that we've supported, I'd have to get back to you on that. But I would say without overstating the case, staffing challenges have been a real issue for long-term care long before COVID. As with many other things, there are just challenges in that sector. So staffing continues to be tight, no question about it. But in terms of those like emergency situations where there aren't enough staff with very little notice to provide the necessary care, that situation seems to have stabilized with better proactive planning on the part of the facilities.
Thank you.
Thank you. We do have another question from the line of Pasadena Richard from Minnesota Public Radio. The line is open. You may ask your question.
Actually, that was basically my question. I had actually been wanting to know whether you could tell us how many long-term care facilities have asked for staffing help. So if you have those numbers, that's great. But otherwise, you can just send them to me via email after the call.
I don't actually have that data right at my fingertips, so we can get back to you, Catherine. That's Catherine Richard, right?
Richard, yep. Mm-hmm.
Okay.
Thank you again, ladies and gentlemen. If you would like to ask a question, you will need to press star 1 on your telephone keypad. There are no further questions from the line presenters. You may continue.
All right. Well, thank you to our speakers and to the reporters on the call today. If you do have a question this afternoon, please feel free to reach out to our office, and we will meet you or talk with you again tomorrow afternoon at 2. Thank you.
And that was today's daily health briefing, the COVID-19 briefing.